Donna Willis for the Learning Channel. What you're about to see is a real operation. This kind of program is not for everyone. The patient, Rod Dirksen, has a time bomb in his chest. He has Marfan syndrome, a disease marked by unusual height, loose jointedness, and a dangerously weakened aorta. Marfan's can bring both genius and tragedy. It may have blessed Paganini with his dexterity on the violin. It struck down Olympic volleyball player Flo Hyman in 1986. Some say that Abe Lincoln had it and would have died prematurely with or without an assassin's bullet. In a remarkable open-heart procedure, Dr. Vince Galliani will now attempt to defuse the bomb in Rod Dirksen's chest on the operation.
I think every person should carefully investigate the person who's going to risk their life. You should feel, I think a patient should feel like the person who's going to operate on him is a platoon leader. And when he blows the whistle, everyone will get out of the trench with him. And that he'll be safe with that person out there where it might be dangerous. And if he doesn't have that feeling, then that's not a person I'd want to do battle with.
My dad died when I was 2 years old. He was 39. He was out working and so forth. He had never been diagnosed with Marfan syndrome, but I'm quite confident that not only did he have it, but his father did as well. All of the individuals involved died at a relatively young age.
Mr. Dirksen's a 37-year-old gentleman who is from Dinuba, California, and he has Marfan syndrome. Marfan syndrome is an inherited defect of connective tissue. The fundamental disorder in Marfan's disease is a weakness in the connective tissue that comprises the junction of the muscle tissue of the heart with the fibrous part of the heart that is made by the aorta and the valves. The heart sits in the chest, just as I'm holding this, and this is a bit larger than a normal heart, but not bigger than Mr. Dirksen's heart would probably be. It is really composed of two pumps side by side. A right-sided pump that is composed of two chambers, and a left-sided pump that is also composed of two chambers. The right-sided pump takes blood that has been used up by the body and pumps it through the pulmonary artery here to the lungs. The lungs refresh it, put new oxygen on, take off the carbon dioxide. And then the blood trickles back to the left side of the heart. The left side of the heart is much bigger and thicker than the right side because it has to pump this fresh red blood to the entire body. In order to maintain efficiency, a pump that squeezes will need an inlet valve, the mitral valve, and an outlet valve, the aortic valve, in order to keep blood flowing one way through the heart. As blood surges into the aorta in a patient with Marfan syndrome, the aorta gradually dilates and becomes aneurismal. This causes three effects. First is the aneurysm itself. Second, the dilated aorta can no longer support the aortic valve, which leaks, causing blood to flow back into the heart, making the heart less efficient. Finally, the coronary arteries are moved away from their normal position. In order to repair this, three steps must be taken. First, the aortic valve must be replaced to prevent the aortic valve from leaking. Secondly, the dilated tissue of the aorta must be replaced with a strong Dacron tube. And finally, the coronary arteries must be connected up in a new way. And so people with Marfan syndrome, as they develop this ballooning lower portion of the aorta, can have the experience of having a rupture. And that is no different than being shot in the aorta. I mean, you're gone in 2 seconds because all your blood volume is out in a very short period of time.
I'm required by law to check with you as to whether you have an advance directive. That's like a living will or a power of attorney for
The aneurysm, despite the best efforts of Mr. Dirksen and his cardiologists, had expanded to the point where the rupture of the aneurysm is a real possibility. The rupture of the aneurysm, as we mentioned before, will certainly kill him, 100% probability. When is that going to happen? Because I would like to operate on Mr. Dirksen one day before that happens, so I would not have to risk his life and potentially shorten his life any sooner than I have to.
Obviously, if something goes wrong, although the mortality rate is very low, I mean, I can die either on the table or later on as well. It says in the Bible, that God will take care of the widows and the orphans, and I happen to be the orphan at this particular point in time, and He's going to take care of me. And, well, I mean, my life is in order to, the best that I can, personally do it, and He's got to take care of it.
Second chances and mulligans are common almost everywhere else in life, but in our business, getting it right the first time is critical, and therefore we tend to be sticklers for accuracy. One of the most interesting things to think about is that there's nobody practicing cardiac surgery today who wasn't alive before there was cardiac surgery.
You ready? Knife ready, please. So once I make the incision, the operation starts. Let's rock and roll.
Once we've made the incision with a knife, we then go on and deepen this incision with a cautery. A cautery is an electric knife that not only cuts the tissue, but also seals some of the small bleeding vessels. Once we've cut through the soft tissue with the cautery, we then use a saw with a little foot on the bottom of it to protect the heart, to divide the bone that sits in front of the heart. This is called the sternum. Some blood comes out, and we do this, of course, from the bone. And so we suck that blood into a machine that saves it and be reinfused into the patient later in the case.
As we're watching this, I want you to think about that patient. What if that was somebody that you cared about? So think about somebody you care about. I want you to look at everything that goes on in this emergency, in this operating room, including the patient himself, and think about what you would want people to know about that loved one that you have when they're taking care of him later.
Rags, the tractor. No, something like the tractor. The Roman tractor too. Okay, so this is the tissue that lies right in front of the heart here. There's a bit of lawn. There's a lawn right under us here. We'll be opening this and showing you the heart in just a second. It's entering the pericardium. Now you're beginning to see the heart.
Yeah.
What we're doing now is dissecting the top of the aorta, right where it comes to the arch, and we want as much room up here as we can because you can see the aneurysm down here now. This is what the normal aorta should look like. This is its normal width between my forceps, and you can see that this is all bulged out below here. And this is the portion of the aorta that has dilated because of the stresses of the heart ejecting blood into this portion of the aorta. These are coronary arteries that you see as large coronaries that are all curly-cued because they've been pushed out of the way.
As this aneurysm forms, these arteries move up the wall of the aneurysm. And instead of having their normal location, they're moved up so they find themselves now in the middle of this aneurysm. And this makes a major technical problem for us because in order to correct this, we have to bring a new aorta all the way down to where the valve is and still have a way to make blood get from the aorta into the coronary artery so the heart itself can be served with blood just as it was before. And that is accomplished by a series of graftings.
What we're going to do now is further examine his mitral valve with an echo probe that we can apply sterilely to the heart. The reason we have to do that is because the echo probe that's in the patient's esophagus doesn't show the mitral valve as well as it usually does because of distortion of the aneurysm. So this is now an echo probe that's in a sterile sheath. I'll be able to examine the mitral valve. Crank up the gain on that, please. To get this thing awake enough to really see the mitral valve. First of all, he has a small left atrium. Second of all, his mitral valve coapts well in the ventricle. That looks good. I don't think he has enough prolapse to do anything about it. You can see the aortic valve at the bottom barely coapting because of the huge size of this thing.
The echo probe allows us to examine the motion of the valves in the heart while the heart is still beating. And this can be used in the doctor's office from the chest wall as well as directly on the heart as we're using it right now.
He has actually a very thin gracile aorta above the aneurysm. So now, Donna, we'll go on bypass, cross-clamp the aorta, open, cardioplegia each coronary individually. And then sew in the 8 millimeter, or measure the orifices, pick out the grafts and the valves. Sew in the left coronary, put the valve stitches in, the valve and the graft, and then go on from there, okay? No mitral messing around at all, unfortunately. The only trouble with seeing this on video is you miss all the smells. We're going to now insert the tube that brings fresh red blood back to the body while the heart's on cardiopulmonary bypass.
It's probably warmer in here.
There it is.
Is it there?
Let's see blood pumping into it. This is the right atrium where blue blood is returning to the heart. This is blue blood coming back from the body, getting ready to be oxygenated. And this is where we'll put the tube in that will withdraw that blood and take it to the heart-lung machine when the heart's not beating. White nylon. This is a markedly enlarged heart from years of aortic valve leaking, as well as from the presence of aneurysm. Here's arterial blood pressure. This is the patient's heart pumping this blood into the canister, letting all the air out of this tube. Now I've completed the circuit for the cardiopulmonary bypass machine.
During the operation, not only is the heart stopped, but the lungs aren't working either. So the purpose of the heart-lung machine is to withdraw blood from the right side of the heart, where it is blue and just been used by the body, oxygenate it, putting new oxygen on and taking off the carbon dioxide just like the lungs would do, and then return it to the aorta under pressure, just the way the heart would pump it.
All right, now we have a tube in the aorta to return fresh red blood, and we have a tube in the right atrium to remove the blood that needs to be oxygenated. But the heart is still supporting this gentleman. So now we're going to go on cardiopulmonary bypass, and the heart will empty out, and we'll then get ready to start the operation. Okay, Karen, go ahead on. Take everything you can, girl. Now you get a better idea of this aneurysm, which extends across here between the clamp and my finger. With this clamp, we'll cross-clamp the aorta and stop blood from getting to the heart, and then we'll stop the heart beating by making it very, very cold, which will preserve it from deterioration while we're trying to repair this. Say when you've got it all, girl. Yeah. Knife ready, please. Okay, clamps on. Now we're going to open the aneurysm. Now we're going to open the aneurysm further so we can look inside here. Stay sutures, please. Now you get a good view of why this valve doesn't work. If you remember what was discussed about the aortic valve, it's a 3-leaflet valve, which you can now see at the bottom of this hole. We'll make that clear in a moment. Snap. Now we have to move along and get this part pulled off. And this is an ice-cold solution that's going to stop the heart from beating. It's going in the left main coronary orifice, which is where the coronaries take off to give blood to the heart. .200 or so cold, right in here, right in. Might as well cool endocardial now. And now the heart will stop beating, and you'll see it will become very pale in color.
When they stop the heart with ice saline, they call that cold cardioplasia. And when they stop the heart with potassium injections, they call that warm cardioplasia.
Now, we're going to push them into the right coronary. The right coronary opening is right here. Let her up. You can see it tense up here. This is the right coronary, which is now getting cold solution from the inside. That will help to preserve the heart while we are trying to fix this aneurysm.
So now they get to work in that ice cold environment.
As long as the heart is warm and is receiving a fresh supply of oxygen, it will beat. It will pump whatever is inside it. If there's very little blood inside, it'll only pump a little bit. And if it's too full of blood, it might be in an element of heart failure there. That is, there'll be more blood there than it can pump. But it will continue to pump as long as it is served with an adequate supply of blood and as long as it can manage it. And no shock to the body will stop it unless the supply of oxygen to the heart is interrupted. So when we go on the heart-lung machine, for instance, and drain all the blood out of the heart will get smaller because much of its size is derived from the amount of blood that's inside it. But it'll continue to beat even though it's empty. Once we stop the supply of oxygen to it and cool it way down, then of course it will not beat because first of all it's too cold to beat. Remember all of the mechanical and in fact all of the metabolic functions of the body, that is all of our cellular activity is dependent upon us being at nearly our normal temperature of 37 degrees or 98.6 degrees Fahrenheit. And if we are cooled down enough, our body functions slow down or stop.
I'd like to pick a graph that'll fit it reasonably. Scissors, please. First thing to do is flush. Put a little of this ice on the heart to keep it cold while we're having fun also. Okay, first thing we do is remove the aortic valve. Okay, I'll take a 25 millimeter aortic valve, all Medtronic variety, and a 30 millimeter woven double velour Dacron graft for them. Okay? Right. When they come up here, we'll prepare it. Okay, now I'll take the 8 millimeter graft, please. Now here's the orifice of the. Okay, 4 RB1 proline. Hold this like this, Duncan. 4 RB1 proline, please. The first step is to sew this graft over the left main coronary orifice. Okay, follow me now, Duncan.
We'll suture the graft, the small graft, to the left coronary opening. That's the first step in the operation. And that's done first because it's in the back and it needs to be done before other things get in the way. You'll see that by the end of this operation, it's kind of hard to see where you started because we sort of built an operation into this smallish space.
Okay, now this is a woven graft that allows healing to occur on its walls after it's been implanted, and we're soaking it in serum albumin, which is a standard technique, and then we're going to cook the graft. And that'll seal the holes for a while, and after a bit, the patient's body will remove this albumin. The healing process will start. So it's just a way of temporarily sealing the graft so it doesn't leak blood.
Once the small graft is on the left coronary, we'll then push it out of the way and we'll rim the place where the aortic valve goes with 15 or 20 sutures. I have a sense, and I'm sure that other people who do this have the same sense, that they can already see the operation completed and they're just putting the stitches where they know they have to go anyway. And that's sort of a geometrical or architectural sense, so that the grafts turn out to be the right length. The suture lines tend to be in the right place. And at the end of that operation, when you look at it, you should say to yourself, well, of course that's the way it's supposed to look.
One last stitch now and we're out of here. Okay. This is a valve that's held onto a sizer now. Very good, strong valve. 17.
The valve we've selected is a titanium valve, which should last the patient a lifetime.
4, 5, and 5 on there.
You ever listen to heart sounds from somebody who has one of these mechanical valves? You can really hear the click. You'll probably get to this semester on those units we're working on. We have a lot of heart patients.
Try not to look down in that big hole and see how wide the space the sutures are down there, because they're putting them a lot closer up here. Okay, now the sutures have now been placed in the patient's annulus and the annulus of the valve. Now we're going to lower the valve down into position. Rubber, something soft now, yeah. Make sure the valve is well seated. Remove the holder. Now valve, graft, please. Here's this graft that's now been cooked so that it won't leak blood.
This is a Dacron graft that is corrugated to allow us to not have to be perfect when we cut it to length. It's very similar to the graft to the material that is used to exhaust dryers. You've perhaps seen in your own home. This material is used to replace the aneurysms.
my fault, I bumped it. Cut, please. Okay, great. Now, put this graft on top of the valve. Okay, now let me see the little pointer. I'll need the small cross clamp now because I want to stick Pleege into this even though I won't do him any good. Now we'll fill this with setting. Then clamp, please. Pleege needle. Oh, it's stunky wee. It's fine. 300, as hard as you can, basically. So now we're going to pressurize this and see if we've sewn it in correctly. Of course, this isn't foolproof, but it does reduce the likelihood of us being surprised by a leak. Another sucker to be close. Looks good. Scissors. Now this graft is bigger than the patient's aorta, so I'm going to sew this in a little. Okay. All right, now on the right, you can see the graft we've just sewn in. And on the left, if you look down there, that dark hole is the downstream circulation. So that when we sew these two together, we'll have reestablished the direction in which blood flows out of the heart into the patient's body. That's beautiful, Don. Okay, now, down to 200 and let this run into his left vein. This looks fine. Now you can see the graft in place, but the coronaries still aren't hooked up. So what are we going to do about that? We have to... So our next step will be to take the graft, the small graft that we had previously sutured to the left coronary, cut it to a proper length, and suture the other end of that graft to the right coronary artery. A little bit, so I can look at it. It's one of those operations that definitely requires an element of geometry.
Keep talking about that geometry. It always reminds me of putting a sleeve in the dress. Which I could do as well.
Right.
Okay.
I don't think I had to learn any geometry.
It's probably my fault. I don't want to pull it.
It's low.
Okay, I'm not doing it.
And now you'll then see that we have a little horseshoe-shaped graft going from the right coronary to the left coronary, and it will be up against the larger graft. So the last step in the operation then will be to make a connection between the large graft and the small graft, and that's very easy to do.
Having sewn the two ends of this little graft to the coronaries, we're now sewing the two grafts side by side, and this will make the blood be able to flow from the aorta and from the graft. We have a bucket of ice cold, please. Heart's beginning to wiggle a little bit. It knows it's time for this operation to end. Pour it in there. Pour it on the line. Go ahead. And put the, we'll take the daily back. Run the daily, baby. Okay, other stitch, boys and girls. We've reduced this to A and B. What we got to do is sew A and B. I wonder if we can do that. Maybe not. We're now evacuating air from the heart. We're trying to get most of the air out of the heart. Take it off, Tom. Fall off. Clamps off. Hey. Scissors, please. Now this leak, of course, is a hole we left there to let air out. And the heart is now fibrillating. That means it's it's recovering, but it's not pumping blood. This is the mechanism that
You see what fibrillation looks like?
is related to the most common modes of death when the heart won't pump blood, but is actually wiggling around in an ineffective way. Now, of course, it's not a problem because the patient's on cardiopulmonary bypass. Paddles on 10, please. So we get to beat again. Actually, put them up to 20. Pop.
Okay, these paddles are connected to a defibrillator, which is the same device you've seen on various and sundry 911 shows. They're used to restart a heart that has an ineffective heartbeat. Sometimes it takes a couple of small shocks of electricity to restore the heart to a normally beating mechanism. We will gradually transfer the blood that is stored inside the cardiopulmonary bypass machine and that is circulating inside it. We will gradually shift that blood back to the patient, and therefore the heart will gradually fill up and it will begin to pump that blood. And we transfer over a period of a few minutes the pumping function from the cardiopulmonary bypass machine to the patient's own heart. And that's, of course, an important moment because it's during that moment we'll find out whether the heart is getting an adequate supply of oxygen to its own coronaries.
These are pacing wires that will be used to alter the patient's heart rate as we need to during the immediate post-op period. And they'll be just removed without having to they can be removed without having to open this chest up, of course.
Spread them out to the.
800. He is quite clever. Thank you.
Maybe these clamps are removed later.
Go ahead, Beck.
That's just making cover. Couple plastic.
Matches. So you can see now here was the wall of the aneurysm. We've sort of installed this repair. Here's the other wall of the aneurysm. Here's the coronary reconstruction part of it. And now if we can, we'll sort of close this over, but that's not essential. It helps to control bleeding and it helps cover all this foreign material with a biologic Band-Aid, if you will.
A lot more regular now.
Something like it's supposed to look. Now we still are concerned that we've left air inside, and the air, of course, can have an effect on how it's. Oops, he just had some air in there. Take a little off. That's leaving there.
Jiggling the heart like this and shaking the retractor a little bit helps to mobilize any air bubbles that are lying along the inside of the heart. And it's important to remove air from the inside of the heart because air blocks the flow of blood through very small blood vessels. By the time the air bubble gets down to the capillary level, it cannot pass through capillaries. So if we left lots of air bubbles inside the heart and allowed the patient to then beat, the bubbles would be evacuated out of the heart and into the circulation. They would go to the brain and to other organs where the air bubbles would get smaller and smaller until finally they blocked microcirculation and oxygen wouldn't be able to be delivered at the capillary level. That is, even though blood was being pumped to that area, those tissues would be starving for oxygen because these little fine air bubbles would block the flow of blood. So what we try to do is evacuate all or nearly all of the air from the patient.
More blood than I like to see. I'm sure. The heart's now beating again and supporting the circulation, the patient's circulation, and the cardiopulmonary bypass machine's just been turned off. And now we're trying to figure out whether we have more bleeding here than we should have, or whether there's anything we need to do. Because once we go into the mode where we take the tubes out of the patient's heart, it'll be harder and more problematic to go back on the heart-lung machine. His cardiac output is very, very high. It's in the 6s probably. But really, he's really whamming away.
His heart's really beating well now.
See this tube coming up through here?
He's really whamming away. Okay.
There's a plastic tube going up through there. They'll leave a tube in place called mediastinal tube to bring that blood on.
Doing here just took a piece of pericardium, this tissue the heart sits in, and we're finishing around the aneurysm where we just to cover it all up with his tissue. Doctor, will you follow this now? He's in the bed with the patient. You gotta throw in there.
And when they do that, it's just left between the heart and the
Yeah, that's the last of the
pericardium.
tubes out.
It'll later just be pulled out.
On the TE echo now, you can see the corrugations in the graft, and you can see the aortic valve opening. See the aortic valve prosthesis opening. Just a beautiful shot. He's really whamming away. Okay.
As you can see, that this is an operation that the verb that keeps coming in my mind is sniffed together. It has to be assembled. And once one part of it's assembled, it's hard to get back to that part. So the most important thing about doing this operation is to do each part perfectly. And if you can put the stitches in perfectly and just sustain a certain level of function for the time it takes to put the operation together, it's actually easy. These operations only get hard if either by virtue of technical failure or by virtue of how difficult the tissues are to deal with. Sometimes they're very weak and they don't hold stitches well, or we're unable to get adequate stitches put in. If that occurs, these operations can be disastrous, particularly from blood loss. So the true premium in this operation is being able to sustain a long volley without missing the shot.
That's perfect. That's absolutely perfect pressure, perfect everything. That's where you want to be.
Okay, Duncan, if you finish closing the skin, I'll go talk to the family.
Thanks for your help.
Dr. Neil Alcott, 1524, Dr. Alcott, 1524.
I'm gonna go talk to the family. All went well.
It went well, huh?
Okay, so now that you've seen that surgery, when that patient leaves that OR and goes back to the ICU where he'll first start to recover, what are the things that we want as nurses? What are the things we want to happen for that patient? Pain management, okay, anything else? You want his blood pressure to do what? Do you want his blood pressure to stabilize? Certainly. Anything else? let's talk goals. Talking goals. Blood pressure stabilized. You want pain control. So take your monitor, the output, and put it in a goal form. Adequate perfusion. What else? We've got adequate perfusion, so we want him to perfuse well. We want him to have pain control. We want his blood pressure to stabilize. I'm sorry? All right, you want him to be infection-free, so you don't want him to develop any infections. That's another goal. What infections is most risk of developing in the immediate post-op period? When y'all were in med-surg, did y'all talk about cardiac? Did y'all have a unit on cardiac? Oh, you did. Now's the time to recall some of that information. What else do you want for your patient? Let me ask you this. If you were looking at that patient as your loved one, is this the nurse you want taking care of him? What you're hearing in here on the people you love? Are you going to take care of any patients? When? When are you planning on doing it? And when you do plan on doing it, are you thinking you're going to wake up and all this knowledge is going to be available to you? How many more days till graduation, Gabe? 95 days you're going to graduate. Within a few weeks after that, you will be independently taking care of patients. Are you thinking in that 95 days to a few weeks later, you're miraculously going to know how to take care of these patients? No, you're not. You've been here how long in this program? And you haven't learned it yet. So when were you planning on learning it? You have to have some ideas. When is it? I would suggest now. One, if you don't learn it now, you won't ever have to worry about practicing in a few weeks because you'll have to take this class again. So I would suggest now, knowing this stuff. So start going back into your brain where this is stored and pull out what goals do you want for this patient. If you'll think of him as your loved one, those goals will come much easier. What do you want for him? I'm sorry? Okay, so what's the goal with instead of spirometry? What's the goal? You're telling me interventions, what's the goal? Adequate respiration, adequate respiration. That's another goal we want for him. What other goals you want for this patient? We've listed quite a few. What ones have we listed? We haven't got them all, but what ones have we listed? We want tissue perfusion. What does that mean, tissue perfusion? What tissues are we wanting perfused? Just the cardio? If his heart's perfused, we're happy, that's all we need? No, that's not going to be all we need. All right, we want tissue perfusion. That would be a good one. And what do we mean by that? Well, we certainly want his heart. What other tissues are primary that we need for perfused? Brain would be a good one. And the kidneys would be a good one. Well, those right there, he gets those three, we're going to be a whole lot happier. Then we're also interested in peripheral, are we not? Okay, so tissue perfusion. We said pain control. We want that. We want infection-free. And we wanted adequate respirations. We talked about the blood pressure, but really we want adequate hemodynamics. And one of those hemodynamics blood pressure. And what infections do we think he's at most risk for early on after the surgery? Do we know? I'm sorry, sight, wound. Is that the only one? Lung, yeah. Those are the primary ones that we're going to be concerned with. Have we hit the primary goals for this guy? So this very first unit of instruction in this course is to talk about what we're going to assess, how we're going to prioritize those assessments. And the first thing you look at when you're ready to assess a patient is you think about which body systems you're wanting to improve. Which ones you're wanting to improve. In this case, what is the top body system you're concerned with? Cardiac, and why? Why did you choose that? That's absolutely right. So why did you choose that? Because they did major surgery on his heart, did they not? I mean, they literally opened his heart up. Talk about open heart surgery. This is open heart surgery. Because they actually cut into his heart itself, not just work on the outside like they would with the coronary artery bypass graft. This is definitely open heart surgery. So the cardiovascular system, primary system that we have to assess. And we're looking to see that with that system that the hemodynamics have returned to good, that we have good tissue perfusion. Those are the two goals that we're going to work on with the cardiovascular system, aren't we? We want to make sure he returns to solid hemodynamics and that he has good tissue perfusion. That's what we expect as far as healing is concerned for this guy. What's the other body system that is primary? Respiratory. Why? Because they stopped those lungs, didn't they? They don't only stopped that heart and worked on it, they stopped those lungs. They stopped them. So they have not been working for a period of time. And we said we want adequate respirations. So we're also going to assess for pain, are we not? And infection. So our priorities in our assessment, so we're talking about just what we're going to prioritize in order to look for healing, what we expect to happen. We're going to have to assess the cardiovascular system, the respiratory system. We're going to have to do a pain control assessment, and we're going to have to do a skin wound assessment as well, right? We need those assessments just to look for what we hope will happen. So if we're going to do those assessments, then we're going to start with our priority assessment, which is cardiovascular system. When we say assessment, there are two parts to assessment. What are those two parts? When I say let's do an assessment, there's two parts to an assessment. What are they? Objective, subjective data. So how do we get subjective data? It's what the patient says or the patient's family says or somebody else, somebody outside of our own person says, right? That's subjective data. So we're going to get objective, we're going to get subjective data. Subjective data is what the patient tells us or what the family members tell us or visitors tell us or somebody that's not us tells us. So what's objective data? The stuff that we collect, right? The stuff that we see, smell, taste, hear, those kinds of things, right? That's objective data. So when we talk about subjective data, we're primarily talking the history, aren't we? The patient's history that they give us, the stories that are told. It's collecting that data. And when we talk about objective data, we're talking about the physical assessment, the physical exam data. So if we're going to do a physical exam, the physical exam part of assessments, there's 4 parts to physical exam. What are they? Auscultation, palpation, percussion, inspection. That's right. And inspection's the first one, isn't it? So we always inspect. We always inspect. We look to see what we can see. So when we talk about the cardiovascular system, where we have the goals of adequate hemodynamics and adequate tissue perfusion, that's our ultimate goal. When we inspect the cardiovascular system, what are we looking for in inspection? Skin color. Skin color. We want it generally, and we want it in the fingers and toes, don't we? Skin color. What else are we looking for? What are we looking at? Inspection. With the cardiovascular system. Yeah, you might call cap refill. Some people call that palpation. I'm not picky about that kind of thing. But certainly cap refill. Anything else that we're inspecting? I'm sorry? The incision site? Anything else that you're looking at? Yeah, you might look to see if you can see any dry skin or any diaphoretic skin. We'll certainly feel for that too. Sometimes these things kind of blend together a little bit, but certainly skin moisture and skin temperature. You know, we're going to want to know that as well. Anything else that you're inspecting? Edema, very good one. Yeah, we're going to inspect for edema, aren't we? If there's any edema in the blood. How does edema occur when there's cardiovascular illness? What happens that causes edema? Decreased perfusion. The kidneys causes what? Doesn't have to just be to the kidneys. How does decreased perfusion cause edema? How does it cause that? What's going on in the body itself that causes edema? The retaining fluid, why? Maybe the kidneys can't get the fluid off. What if the kidneys are functioning okay and you still have edema? Now what's causing? The heart's not pumping. So you either have the heart not pumping well enough to recirculate the fluid, or you have kidneys that are not filtering out the fluid. So you've got two things that can be going wrong here. So that's why we look for edema. It tells us something about the heart or the kidneys. So we've got to look for those things. We've got to look for that. So we've got to look at for edema. What are we going to palpate? Pulses. We're going to palpate pulses. Which pulses? All of them. Yeah, we're going to palpate all of them. And we're going to palpate them bilaterally to determine if there's any differentiation between the pulses on both sides of the body. Now, why do we care about that? What kind of test question do you think I'm going to ask about this? Anybody want to guess the test question I might ask about this? Am I going to ask which one of the out of the different parts of the physical exam, which one is included? Which one of these four is included on the physical part of an exam? Because y'all have met me before, right? No, I'm not going to ask that. No. So you can memorize those things that I said. There's four parts: inspection, auscultation, palpation, and percussion. That's a good thing to know. Because I'm going to ask questions about those four things, but I promise you it's not pick one of these four that happens to fall in that list of four. We're not playing word match game on one of my exams. You're going to take care of this patient, aren't you? Yes, you are. So let's think about when we're palpating, or when we're palpating, yes, so when we're palpating, what are we palpating for? What's our even reason for doing palpation on a patient? any of those pulses, the pulse rate, how regular is it? Whether it's bounding, whether it's thready. What would cause a pulse to be okay in the right atrial, in the right radial, but not in the left? I'm sorry? Occlusions, thank you. Occlusions would cause that, certainly. So we've got to do all of the pulses, and we've got to do them bilaterally, because if occlusions occur, it's going to affect one and not another. So you can't just do one side and say, hey, I've tested. We've got to assess for both. So pulses are one of the things we're going to palpate. What else are we going to palpate for? You want to palpate the edema? See how deep it is, right? The pitting, how pitting is it? You can certainly palpate for that. Anything else? Temperature of the skin. Now, is it warm? Is it cool? That'll also tell us, is it dry or is it moist? When we touch it, we can tell that. We also palpate for tenderness and any masses. Primary reason we palpate, tenderness and masses. Find areas that are tender and find areas that are edematous, solid, cyst-like, those masses. That's what we palpate. What about percuss? Why do we percuss anything? You can find borders of masses. Exactly. Any kind of, like an organ, if it's enlarged, you can find where the enlargement goes. How big is it? If it's a tumor, you can find the percuss to find the borders of that tumor. It will also tell you what else about the tumor, or about the mass, or about the consolidation. What will it tell us? If it's air-filled, fluid-filled, solid-filled, tissue-filled. Is it air-filled, fluid-filled, or tissue-filled? That's what percussion does for us. So you can percuss across these masses, and you can tell where the borders are, but you can also tell if this mass that you're percussing on, is it likely to be air, fluid, or tissue-filled? So that's a good thing to know. One of my graduates from many years ago is now in nurse practitioner school. And she is very involved in providing care in Africa. In fact, she's adopted a child from Africa. And she's very involved in this, going to some of the poor regions of Africa, Southern Africa primarily, and she provides this care. And so she's on Facebook, she's in the United States right now going through a nurse practitioner program, and she posts on Facebook her frustrations, in essence, about studying for an exam, and she said something about tactile fremitus. Who cares about tactile fremitus? I couldn't let it go. And so I put in the comment section, I said, well, anyone who suspects a patient has consolidation, in particular, let's say the lungs, people who have consolidation in the lungs, perhaps from pneumonia, and they don't have access to an x-ray or don't have the money to pay for an x-ray, the nurse could then determine whether or not there is fluid there, and it would confirm pneumonia without an x-ray. So I would think people who are in that predicament would be very interested in tactile fremitus. To which one of her friends put in comment, oh, like people doing care in Africa. To which she replied, thank you, Professor Lockhart, for teaching me even 7 years after I've been out of school. So yeah, these different techniques can be quite useful in certain situations, can't they? Yes, it's not going to be helpful for you to do a lot of percussive in a hospital where you have x-rays everywhere, but if you're doing home health, especially if you're doing home health in a rural area, it might be very, very useful to you. So then we also will need to auscultate. So what are we going to be auscultating for? Heart cells. Remember right now we're working cardiovascular system, adequate hemodynamics, tissue perfusion, we are going to auscultate heart sounds, which means we need to know how to auscultate heart sounds. So how do we auscultate heart sounds? On the skin, good one. No, that is not allowed because some people will auscultate over gowns, won't they? So on the skin is a good one. What else? That person gets a buy, came up with something. Somebody else has to answer now. With a stethoscope. So which side of the stethoscope, BK, are you going to you do that's coming. Which side? The diaphragm, why? What does the diaphragm listen to? Low frequency sounds. Okay, so when we put this diaphragm on the skin, where are we placing it? Second intercostal space to the right of the sternum first, right? And when we do that, we're listening to what? What sound are we hoping to hear? S1? Well, you'll hear both of them, right? You hear S1, S2, but one's going to sound more prominent than the other, right? At that spot. Why? Which valve is making that sound? The aortic. The aortic. Which wasn't that the one they just replaced for this guy? We ought to be able to hear that one's aortic valve without even having the stethoscope. If it's real quiet in the room, you'll hear it go click, 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 click. You'll definitely hear it with the stethoscope. It's very loud in those artificial valves, very loud. Patients will tell you they can hear it, you know, after that. In fact, if we watch the rest of that film, he'll tell us that. He'll tell us that he can hear it. Okay, so that's the first heart sound. Ooh, that's painful. Now let's go to the second one. Where is it located? Second intercostal space, left of the sternum. And which valve are we listening to? Pulmonic. Okay. Now then, where's the third sound we're going to listen to? Fourth intercostal space. You got one before that. It's not really a heart sound, but we listen to it. What is it? Erb's point. Where's it located? Third intercostal space to the left of the sternum. And how do we listen to Erb's point? What are we listening for? How come y'all don't remember this? You were taught it in health assessment. How come you don't remember it? I remember it. Who has been in health assessment since I have been in health assessment? Oh yeah, all of you. I remember it. How come you don't remember it? Yes, what specifically about the S2? Oh, close. We're listening for that split and that S2 sound. That's the one where we have them take a deep breath. We listen to see if that splits. It's normal. Well, let's see if it happens. Now then we're going to go to the next valve, which is what? We've done the aortic, the pulmonic. What's next? Tricuspid, where do we hear that one? Fourth intercostal space, left of the sternum. And then what's the last one? The mitral, and where do we hear it? Fifth intercostal space where? Mid-clavicular lining. Now I'll tell you why you don't remember those. Because you haven't been doing it. You haven't been doing it. Did they tell you in health assessment to assess hearts that way? Did you demonstrate that in the health assessment practicum? When you were in basic, did you have a professor who said assess your heart that way? Yes, you did. I remember saying that. When you got into adult med surg, the cardiac unit, did they tell you to assess the heart that way? Yes, it's in your textbook. I've got the Lewis textbook. I've seen it. It tells you to do that. And now I'm telling you again. So why don't you already know it? It's because you're not doing it. You're not doing it, people. You're doing it wrong. You're not listening to heart sound. And I know why you're not doing it, because you've done it that way and you've said, I can't hear anything. It's a practice skill. You have to hold that stethoscope in place, you have to close your eyes, and you have to focus on that love dove. And you have to do it a lot. And once you start to do it a lot, you will hear the abnormalities. They will become easier and easier to hear. You must do this. If that patient that was on that operating room table, if that was your loved one, would you want the nurse taking care of that patient to listen to all those heart sounds? Why? Why? Why do you care? If that's your father, brother, boyfriend, husband, you're going to be able to tell, because is the heart working independently of itself? No, it's working together. And so as things start to go wrong, that heart sounds will change, and we'll pick it up and say, wait a minute, we have a symptom of something going wrong. Isn't that what you want for your father, your brother, your husband, your boyfriend, those types of people in your life? Certainly you do. Certainly you do. If given the option, you would clearly choose to have me taking care of your loved one than you. Because I listen to all those heart sounds. You know I would. You trust that, don't you? But you don't do it. You're not doing it. What's it going to take to get you to do it? What bargain I have to strike to get you to start doing the good care instead of whatever you think you're doing? It's not going to be your passion.
Points.
What would it take?
Points.
Points? Well, that's exactly what I'm going to give you. If you don't do it, then when you take these exams, you will not get the points that you hope to get. And then you can repeat this class. Wouldn't that be devastating? Yeah, it's going to be. Don't mess with me, people. You know I mean what I say. You met me before. These tests will not be easy. They will not be easy. Did you think exam 1 was easy? That's why you made a 73 average on it? Because it was so simple? No, it wasn't easy. Did you think I asked questions that nobody needed to know? What do you think? Did I ask questions that weren't applicable to today's patient care? No, I asked very applicable questions. I carefully selected the questions for that exam so that it would be the most common types of things that you're going to be taking care of, not the least common type of things. I specifically selected those questions. So you're going to have to be able to assess. Now we've talked about the assessment of the cardiovascular system. I want you to think about the assessment for the respiratory system, for infection, and for pain control. And I just want to highlight with you right now about pain control. When we do an assessment for pain control, it includes more than what your pain rating is. It includes more than, on a scale of 0 to 10, what's your pain rating. What else is in a comprehensive pain scale, pain assessment? Where it's located, it's characteristics. Yeah, what's that mean, characteristics? Yeah, it's sharp, burn, dull, achy. What else is included? And things that aggravate it, things that relieve it. Anything else? When did it start? How long does it last? And does it radiate? Very good. That whole colder thing. Remember colder? C for characteristics, O for onset, L for location, D for duration, E for exacerbating factors, R for relief factors, and R for, gives us 2 R's in it, and R for radiation. So that will be a comprehensive pain system. So we need to know all of that. Okay. When we get back together, we're going to stop and let you take your doses down. When we get back together, we're going to talk about assessing for the things that could go wrong. So one of the things you need to know is you need to go back into some textbook and find out what's the complications of a aortic valve replacement. Because now you've got to assess not only for these goals that you think he'll make, you've got to assess for the problems that can occur. You gotta be able to differentiate between those. So differentiation assessment. So before you come back on Wednesday, know the complications of the aortic valve. Got a dosage calculation quiz. You can use some scratch paper if you want to. You'll probably need to. Once this